Hello, everybody. This is Susan Clinton, and welcome to Tough to Treat. Today, we're going to be talking about an interesting, complex case of a 62-year-old female that, for all appearances and purposes, looks like it might be joint changes that are the source of what's going on with her. However, join us as we dig a little bit deeper and really look at some combinations of clinical reasoning that really help us uncover the driver of what's going on with her pain and what's limiting her functional movement. So let us know if you like the episode. Find us on iTunes and leave us a review. It would mean the world to us. Thank you very much. Hello, everybody. It's Susan Clinton and my co-host, Erica Melo, and we are Tough to Treat. Hi, Erica. How are you today?
I'm good, Susan. And yourself?
I'm doing well.
Very nice.
Doing well. So we're going to talk today, I thought would be an interesting thing to discuss, is a client that I've seen her actually 2 or 3 times over the course of the last 4 years. And it's been kind of an interesting progression watching this happen. She's a 62-year-old female and has presented with, in the beginning when she started working with me, she was presenting with some right posterior lumbosacral pain. I know we kind of covered that in the past in some of these podcasts.
Yeah.
This one wasn't really any different. It was kind of a normal course of, or what I would consider normal for what I look at, of, the back, the hip, and the pelvis all kind of moving together and had lost its ability to move separately with the motor control, bend overs and sitting flexed, driving in the car all bothered it. So we worked through the major things that we needed to work on, which was getting her to hip hinge as she needed to, rather than, having her back move first when her hips needed to move first. So like with bend over, she would bend at the hip rather than, allowing her trunk to just do all the flexion and all the movement.
Okay.
And so we got her to where she could sit on the floor. We used props so that she would, something underneath her ischial tubes, like a yoga block or a folded blanket.
Yep.
She has grandchildren and wanted to be on the floor with them. She could tailor sit fine, but it was the posterior lateral kind of hip thing that was going on. And so when we got her up on, on a block or up on a folded blanket, she did very, very well. She is also a runner and a CrossFitter.
Oh, interesting.
So by trade, what she prefers is to run more than anything else because it's easy. Put on your tennis shoes and head out the door. When I started seeing her, her husband had started CrossFit about a year before that. And so she decided to start going as well. And she said, she told me, she goes, I love it because it's just a fitness-oriented gym and it makes me exercise every part of my body. However, I'm noticing with the squats and deadlifts and, squatting to do wall balls, which is basically you squat down and then press the ball up, throw it up onto the wall and catch it, things like that. She said that, she felt really limited with it and didn't feel like she could move through those the way that she wanted to, and running was becoming a problem for her.
So quick question. So she couldn't sit in the car. She couldn't forward bend. She also couldn't run and then do sort of ball throws, like squat type things, correct?
Right. Deep squats. So
Deep
like
squats.
the deadlifts, back
Got
squats, the things that would go deep.
Okay.
And so those were the biggest complaints that she had.
Okay.
And, like I said, I saw her for the first time about 4 years ago, and we worked through the issues and got her to, change her squatting position, began to learn to not allow her upper trunk to flex forward over her thoracolumbar area to initiate the squat, but to, really initiate it at the hips, at the bend, and get her into a position that it felt good. She changed a lot of her movement patterns. Very smart person, and did really, really well and was back to running. She never really wanted to run more than about 2 miles, but that was what she wanted to do, and she wanted to do it without pain. One of the things she commented on was that, she just felt a lot more flexible, easier to get into different positions. And that was what she was looking for. She wanted to make the CrossFit and running easier again. And we were able to accomplish that just by getting her to move differently. So it was fairly simple, in the very beginning. I saw her about a year and a half ago, and she was starting to have some knee pain on the right side, which is the same side as where she was having the lumbopelvic pain.
Yep.
And the lumbopelvic pain would be kind of like, every once in a while it would kind of come up, but she knew what to do. But what she felt like she was happening with her deeper squats was that her knee was bothering her more. Okay. And it basically happening kind of in the posterior aspect of the knee. So as a PT, when we start thinking about knee pain, somebody who's in her 60s, maybe some age kisses going on in the joint. I don't like to use the word degenerative because it sounds hopeless. But, she's having some changes. And, so my first thought was, we got a posterior horn meniscus thing that's kind of creeping up here and nicking that posterior capsule. If I wanted to think kind of like a PT, boom, right into the knee, what would that knee be? And it seemed very straightforward like that, so we took a look at her knee because that's what she came in for. She wanted me to look at her knee, so we did. But full extent, full height, like almost hyperextension, like when you did like raise the leg up and you do the heel lag, when you hold under the heel and let the knee, lag, that kind of thing, just really both sides fine, so
no,
like,
no looser end feel or anything on the right side.
Right. I was thinking, okay, I'm going to run into that little bit of that hardened feel here, with the posterior knee capsule, and so I took her through, and I thought, let's just, for kicks and grins, I'll do a couple of ligament tests just to make sure I'm not missing anything, and did the cartilage tests. I can never remember all the names of them.
Me neither.
The ones where you lay them on their stomach, bend their knee up to 90 degrees, and then do the rotation.
Yeah, right.
And I even did a Thessaly's exam, which is one where you stand up, stand on one knee at, I don't know, 10 degrees of flexion and then 30 degrees of flexion and rotate back and forth.
Yeah.
That one bothered her a little bit, but all the other ones were like fine.
Right.
And boy, if you're going to find that posterior horn, you're going to find it sometimes with them in that prone position.
Totally.
And so I was like sitting here going, okay, this is kind of starting to be very interesting. So I decided that I wanted to go back up and take a look at her and her movement and what was going on. And just, I said, we got the knee. We kind of know where it's bothering you. And I forgot to tell you, the things that she couldn't do with her knee pain were, which was very interesting, she was uncomfortable tailor sitting. But so that's, crisscross applesauce with the knees, pretty well bent. And again, she likes to be on the floor. Grandchildren are there.
But she could tailor sit before, though, you said, correct? Yeah, she could
tailor sit before, especially if you put her up on a block or a blanket. But even with a block and a blanket, it was bothering her to tuck her leg up underneath her.
Interesting.
And chronically, she likes to get in that position because she also quilts and does handwork. And so she sits, I said, show me how you sit. She did because I can't get my leg. It bothers me when I do that.
Okay.
And it's like, so that was before I did all the tests, so I was really kind of thinking, knee, you can kind of see why. So I said, okay, let's get on the floor. We got in the chair and looked for us. I said, let's get on the floor. Let me just see what's happening. Put the blocks back underneath her. And she was just really having a lot of trouble bending her knee. So I just asked her, in tailor sit, her left side was fine. So I said, just open your leg out and see what happens. So your knee isn't bent so much.
Correct.
And, just let your thigh come up off the ground rather than going down towards the ground.
Right. And straighten the knee out a little bit.
Yeah. And let's just see. Let's play around. Let's see if we can find a position.
Yeah.
And what was very, very, very interesting was when she lifted her leg up again, her lumbopelvic pain returned.
Oh, interesting. So when she literally almost went into external rotation of the hip a little bit. Interesting.
Yeah. So the more external rotation she went into, the knee pain was worse. When she came out of the external rotation just a little bit and straightened the knee, it became much more of a, posterior lumbosacral kind of pain.
Interesting.
Yeah, it would come out of the knee, but then she would start noticing her old symptoms in her, in that posterior region again. So I'm sitting there going, okay, what do I have going on here?
I'm thinking it's like almost like a straight leg raise, but it's not a straight leg raise.
So I thought, okay, I'm going to get really clever here. So I have a stool. I'm showing my hands here with this. It's about 18, maybe 16 inches tall. Mm-hmm. It's taller than a foot, but it's not 2 feet tall. So I put a pillow on that and had her sit on that.
Taylor sit.
Yeah, and then I said, now go into your Taylor sit. Just like, it would be like putting 2 yoga blocks underneath her instead of 1. Mm-hmm. And the interesting thing was in that position, she could completely Taylor sit. I mean, she could get her leg underneath, just like the left one, and she would have full external rotation.
And no knee pain.
No knee pain and no back pain.
Interesting. So that's isn't that what you did 4 years ago as well? Sort of a similar easing position.
But I had to get her up higher, and 4 years ago she didn't have the knee pain.
Right. Interesting.
So some changes. So I asked her as we were sitting there and kind of playing around with movement and stuff. I just wanted to know, like, what's really changed? Mm-hmm. And in the last, because it had been about 1.5 years or so since I had seen her. And I said, what's really changed here? Because, you were kind of moving along. I didn't hear from you. So I thought, no, this is good news. You're kind of, doing really well. Well, she had a parent who was in crisis. And there was a lot of things that had to occur around the parenting crisis and taking care of everything that was going on. Mm-hmm. So basically what happened was that she went offline for like about 7 or 8 months. She tried to do things as she could, but her time was so consumed with, getting placement, taking care of medical issues, doing all the moving, all the stuff. And she said that, because I asked her, I said, do you know when that knee, do you have was there a day where it was like, ow, or something, like an event? Mm-hmm. She said she thought that there was one day when she was lifting and pushing, but she said it just seemed like the pain came on slowly. So it doesn't sound like a traumatic event to me. It sounds like, maybe something that got into a bit of, kind of a weekend warrior-ish type thing. You stop exercising for a while because you've got all these other things that have taken priority. And then you're into back almost kind of exercising by doing all the lifting, pulling, pushing to move somebody, out of a house.
and so running, this time the knee pain came on with running. So how far could she run before it set in?
So she was running and the knee would bother her. So it wasn't a big deal. And she would say sometimes it would feel better with running and other times it just wouldn't.
Right. But
it didn't stop her,
Got it.
So, so she was back to, but her back wasn't bothering her with running.
Right.
Just her knee.
Yeah.
And then so just kind of looking at some of these other things, she just wasn't realizing, she would say occasionally my back would bother me. But then when she got on the floor, she remembered, oh yeah, and every time I'm here.
Muscle memory.
I just haven't been on the floor in a while, so, those kinds of things. So it was interesting looking at this because it was kind of going back and forth. And after doing the knee exam, because all this I did was after the knee exam, and so I said, what are you doing to help this feel better? She told me, she said, I'm using a strap and doing some aggressive stretching. So I asked her to show me what she was doing. So she actually I gave her like a yoga strap, something very similar to what she has. Mm-hmm. And she put her foot in it and raised her leg up straight and forced her knee to go straight and pulled down on her foot as hard as she could. And I asked her, I said, can you tell me what's happening here? She goes, oh yeah, I'm getting extraordinary pain in the back of my knee, so I just push harder.
Oh God.
And it was like, okay.
It's amazing what patients do a lot.
That
makes them worse. It's crazy. You have to flesh it all out, it's crazy. Okay, that's okay.
So you could probably guess what I'm thinking at this point.
Right.
We got a little neural tension.
Totally. I mean, when you had her in the Taylor sit and she's straightening her leg, it's like almost like a side-lying straight leg raise or a side-lying femoral slump or something.
That's exactly like a slump. Exactly like a slump. And that's what I was seeing. And if I could, so when I sat her up taller,
Mm-hmm.
You know, she was able to maintain a little bit more
Of course.
a less flexed position of the spine, and everything got better
Love it.
immediately.
Love it. Yeah.
You know,
Yeah.
so we're back to that whole thing of when she collapses down and allows her lumbar spine to flex, then she runs into trouble again.
Yeah.
And she had she went through a tough time. There was a lot of things that were going on that occupied her time, and she wasn't really caring for herself as well as she wanted to. Mm-hmm. And the only thing she knew is when she was having the pain in the back of her leg that hurt, she just said, "It has to be my hamstring. I just need to stretch it."
Right. Right. How far could she go? Like, how was she flexible?
No, not really. She would get close to about 80.
Right.
So, I mean, not unflexible at all.
Right.
But, I mean, the pain she described was pretty awesome pain. I mean, she was talking about it, burning in the back of her knee, and sometimes, maybe she would feel it coming up the leg a little bit, and, but she just felt like she just had to stretch it. And I said, well, how's that working for you? Like, does it help you? What kind of changes do you get? She goes, none. That's why I'm doing it so hard, because I can't figure out how to stretch this.
Right.
So, which is kind of a common theme of what I seem to be seeing right now.
I don't know why people feel stretching something is the answer.
Yeah,
I just don't.
They read a lot and they feel tightness because it is. And, what's happening was her hamstrings were just guarding like crazy.
Yep.
Because she was having this kind of neural tension type pain thing going on.
Right.
I guess I could have probably said maybe it was nerve root, but she didn't have, again, no fatigue or weakness, no changes in reflexes, no sensory loss. It was just that kind of, pain that would come on, and mainly when she would get into those dural slump positions.
Right.
So she could bend over if she did it if she bent at the hips or allowed her knees to bend, she could do it without a problem. But it was those prolonged, those kind of like you called it, dural slump positions that just really gave her a hard time.
Yeah.
So we changed that. And I got out the anatomy books and showed her like what I always like to call with my patients, I call them long tracking nerves. We have these nerves and these nerves. Then we have the ones that go all the way down the arm, all the way down the legs, those long tracking nerves. And I said, they can get caught up in different places. And sometimes they can get super sensitive, and I said, and you've had this kind of start at one point during time, and maybe some sensitivity got set up at that point, but you were moving and you were exercising pretty consistently. So you were keeping it mobile as long as you didn't get it into the positions that were making it kind of like fire off at you.
Exactly.
And, so she agreed, yes. And then I said, and then you did the best you could, but you had a lot of things you had to take care of. And I'll tell you, stress is going to play into this hypersensitive nervous system thing too.
Oh, totally.
We know that endocrine changes, stress changes, all the kinds of stuff. Plus you weren't getting the movement that you were getting before. You were moving, but you weren't getting, I'm taking care of myself movement.
Right, to flush the
I'm taking care of somebody else's movement.
Right, exactly. And you often wonder if when she was running, if she did, because it was random almost, did she run after a prolonged period of sitting or a prolonged period of doing something that triggered it? Because it was so random, it was hard to say. But because the running, in a sense, she said initially, well, that was her back pain, made it feel better because it flushed tissues out. But with the running now, with the knee, maybe it didn't bother her one day because she didn't have a trigger, a stress trigger or something like that at this point, and because when you have patients who have knee pain with running, they're generally pretty consistent with running, right?
Exactly, right?
Yeah. And hers wasn't. So
right, hers was not at all. So, which was another kind of clue that is this really a knee thing, or is it something else, or could it be two things? Could it be anything and something else, right? So we were still so what I did was I sent her home, and it's so funny that you brought that up about when and running, I wanted her to go home with some mindfulness, and I said, come back in a couple of weeks. We've worked on some neural tension exercises, some easy ones. I obviously said, use the strap, but let's use it the different way. Let's back off. Let's work let's cozy up next to the stiffness or the tension, but not push through it. Let's kind of do a little bit more dynamic, like up and down stuff and things like that, just to get things moving a little bit better. and to give her really good movements to do that she was already used to doing, but in a different way.
Yeah.
So we weren't like going into that full blown stretch that was just like, pulling her into all that dural tension and everything. And kind of went back over, when you sit on the floor, be sure you use a block, be sure you do some of these things. In fact, you may need to build your block up for a little bit till we can get this to settle down. So, and just, kind of reminded her of some of those things. And in the meantime, she said, can I go back to CrossFit? Like, sure. But here's the rules, the rules still apply there as they do with anything else that you do. I don't want you working through pain.
Right.
I want you to be mindful, and I want you to move. I want you to move in many different ways, but I want you to only go where it feels good.
Yep.
So absolutely, if you want to get back to your community and go do it, we're trying to settle this down. So keep that in mind. This is a short-term thing, for a long-term solution, but let's get this settled down.
Yep.
And then she was to make some decisions about running and come back and tell me when she was having problems, and she was supposed to notice a whole lot of things. And one of them was running uphill versus running downhill. And stairs, I wanted to know a little bit more about if she was going up stairs, what was happening there. I'm looking for those flex forward kind of postures and things like that. I didn't give her a clue. I said, just let me know if you're on a hill, off a hill, uneven surfaces, if you're fatigued, had you been sitting a lot before you ran, those just the kinds of things you were talking about, which was really pretty funny. And, so she comes back in a couple of weeks, and very interesting when if she had been sitting for a long time, that's when she felt like she needed to exercise. So she would go and run. And when she sat for a long time and went and ran, it bothered her a lot more than if she had been moving and doing things and decided to so at CrossFit, when they would go and run around a few times, she was fine.
Yeah. Interesting.
Right. So it did become kind of that, okay, so now we know where the, kind of the prolonged posturing that needs to really change. And so I helped her kind of build some parameters around that,
No, I'm sorry to interrupt, but I always tell patients, nerves, I don't know, I think this was a David Butler course I learned this in. They're like, nerves are blood suckers. They need oxygen, they need blood flow. So it doesn't surprise me that after a prolonged period of sitting,
exactly,
she goes up and moves, it aggravates it, so very interesting.
And so consider it for those who still want to kind of hang on to a little bit about that knee. I'm still not convinced that there wasn't something a little bit going on internally in the knee as well. But if you think about prolonged posturing and sitting, because this person there was a lot of things that she was having to deal with paperwork wise.
Yes. Around
all of this stuff. This was out of character for her to have to sit in these postures and positions for as long as she was doing, trying to get this stuff done.
Right.
And sometimes in the midst of stress, we don't realize how long the period is lasting. It's just like, okay, I'll just get through this. But, weeks and weeks of just getting through this can be longer than we think.
Yeah, and our self-care goes down the drain.
Yeah, and so the knee being flexed all the time, it's not all that absolutely wonderful for the joint either, because it needs to go into extension. It's the synovial joint needs to end range for nutrition. She could get to end range. That was the thing. Maybe the knee was a little bit of a problem, but not nearly as big as this other stuff. Correct.
It's probably secondary. I always tell patients, especially if they've had, let's say, knee pain for a long time, it may need to get treated, but not as much as another area, I believe, whether it's the nervous system or the hip or the thorax or whatever, or the foot. The knee is definitely sensitized, and you almost want to validate their symptom in a certain way, depending on the person's, if they're a coper or non-coper when it comes to pain. But I always say that it's your pain. I don't even like to use the word generator, but the source could be elsewhere. So just be open to that. And you get the buy-in, like when you had her you do the task. Like, I'm so into having the person do what makes you hurt. If it's in the realm of, the clinic, if you have a problem running, let's see if we can get you to run a little bit. Or if you have a problem saying, show me the issue. Just don't go through a cookbook, bend, extend, squat, get into the position that makes you hurt. And let's see if we can find a way to get you out of it. And then you've got your answer. You just have to clinically reason up the chain and down to find out what the source is.
Right. So I just thought it was fascinating. She's checked. So anyway, quite happy. Went back. Still to this day, she checked in with me a few weeks ago, and the only thing that had occurred between the last time she saw me and this time is she did feel like that she was having a difference in her knee pain, not so much posterior anymore, but now it was kind of on the inside, that she would call it, like anterior medial, coming across the side and the front of the knee a little bit. But also coming down the calf just a little bit. So at this time, I wasn't going to allow myself to be fooled with the knee again. I did check it to see. But she could get her leg up underneath her. She could tailor sit, so she was doing some of the things that she wanted to do. She wasn't able to get lower than the yoga block with the tailor sitting, or her back would start to hurt. And she did notice that if she was driving the car for long periods of time, because now this parent is far away. Her parent lived far away, but now they're still far away. So there's driving, longer driving than normal now as well. And so, with the legs stretched out in the car.
Correct. Right.
She feels that. So back up to the spine we went, and, because it's starting to act a little bit more like an L4 kind of dermatomy type of thing. So tested those out again. Sometimes you have to have a lot of nerve compromise before you start to get muscle weakness or for the fatigability, but there was nothing, there wasn't anything, but that didn't mean that her nerve wasn't,
correct.
I've known all along that there's been something going on. She's at the age, maybe she has a little foraminal, issue that's kind of happening there. So we just needed to kind of think a little bit different, and she knows how to get out of that kind of sitting except in the car. So we problem solved the car. We went out to her car. I said, sit down in your car and show me what you're doing. And so we took the blanket and we took a couple of towels and we just moved things around. And she said, I think I need to buy another car. And I said, well, I'm not going to, I said, test drive it for a while if you do and make sure that is, I said, cars are cars. And I said, you might do better sitting on a seat that's a little bit more benchy. Right. Instead of a deep bucket seat.
Correct.
But that doesn't mean that you have to give up your car. So let's just figure this out. So she just didn't think about bringing the car towards the steering wheel just an inch. Made a huge difference in her knee pain. It just kind of like took it away, and it was like, it's just that last bit of you having to press on the,
It's like a prolonged slump for 50 million miles.
With your foot going back and forth to the brake because it's the right side. I know. So she was thrilled about changing that. So it was really good. Again, it would have been really easy to fall back into, it's a knee problem, it's a knee problem, it's a knee problem. And really, it's still more of a nerve root, maybe pain issue, neural tension kind of problem. And again, trying to kind of figure out, how do you get that, and how do you, get that to calm down. This has been kind of running along with her for a while now. So, we talked a lot about the sensitive nervous system. And, she's not one to be taking a ton of NSAIDs, thank goodness, because I've had people like this that are just taking NSAIDs like crazy.
Incense, you mean?
NSAIDs.
NSAIDs. He said incense.
NSAIDs. That's bad, the non-steroidal anti-inflammatory.
Got it.
So I talked to her a little bit about, we talked a little bit about diet and diet change and some things. And I said, when you have a nervous system that's gotten into this hypersensitivity that's just been kind of hanging around for a while, sometimes we need to kind of find some other ways in to hit it. You're doing all the movement things right. You're still having a few of these persistent issues though. So let's just pay attention to that a little bit closer. So some of the things we talked about, she kind of just laid out her day for me, what she eats, what she drinks. There was a lot of caffeine in there. And there was, just a lot of dairy as well. That was just one of her things. So we talked, and I said, the caffeine, she wasn't really having any bowel bladder issues other than some urgency frequency with her urinary, system. And so we talked a lot about that. And I said, she really didn't want to talk too much about her bowels, but I could promise you she was probably somewhat constipated.
Right.
and that's going to make that whole back issue even escalate. So anyway, I got her to consider beginning to start decreasing her caffeine somewhat. And I gave her the information on eliminating, some things in her diet. And I said, it's just for a short term, but see how you feel.
Right.
You just give it a try. And the biggest one, I said, if you're going to do anything on the elimination, don't eliminate everything that they have on this piece of paper because you'll go crazy. It's too much. I said, go for the big things. And I said, just eliminate the dairy and see how you do. Just give it a try. Replace your butter with ghee, figure out things to replace the stuff with. Email me if you're having trouble finding something to replace something with. Got resources, we can do that. But give it a real try and see how you do. And so the cool thing is that I heard back from her just last week. And she said getting rid of the dairy has been a miracle in her life.
Wow.
That she no longer, when she told me she wasn't constipated, I really think I was. And I'm not now. And the urinary urgency has really improved. And she's sleeping better at nighttime. And she said, I'm not so sure yet about my knee and my leg stuff, but it's, she goes, it is different. And she goes, I don't know if it's the movement or if it was not doing the dairy. But she was grateful for the changes from getting rid of the dairy and decreasing the caffeine because she's sleeping better at night. When you sleep better at night, everything's better.
Totally. Yep.
So she was in. She goes, I think I'm going to go ahead and just kind of keep away from the dairy for another month, and then maybe I'll try doing, because they always say after you've been off of it for a bit, then go back in and kind of test.
Correct.
A little bit here and see how you do, then go back to nothing and then test another one and see how you do, which is the appropriate way to go.
Yep. So
and
for
if it bothers you, you'll know pretty quickly. So
I've done the no dairy. It's very true. Everybody's so different. So for the listener, so in terms of like home program, you gave her some neural tension things to do, like slumps or straight leg, easy mini ones, right?
So I started without the slumps because that was a big trigger, right?
Correct.
But you could, for somebody less sensitive than she was, I could start with a slump and just only raise the leg a little bit. But she likes to go hard.
Right.
So I got her to really actually sit up straight, almost with an anterior tilt and a little lordosis.
Got it.
On her legs and sitting that way,
perfect.
Pronate, pointed coming up, dorsiflex coming down. The wall.
In full extension and sitting.
Yeah,
sitting up straight.
Working on things like that, and then laying on her back. She loved using the strap, so I just changed the way she was stretching with the strap.
Got it.
So that she wasn't pulling into the tension, but she could move in and out by letting the knee bend and extend, rather than trying to pull down on her foot so hard.
Exactly. Yeah.
And then started playing around with moving across midline a little bit and back out, into abduction, external rotation a bit.
Yep.
Some of that as well. So she was doing some of those, and then as she came in that second time, I actually added in, some of the like downward dog kind of positions.
Love it.
What she was doing CrossFit anyway. So she's already been doing the put your hands on the floor and walk out to a plank and then walk back up. So we kind of did some of that, but we pulled the legs into, much more of a wider stance.
Right.
And so she could keep her back a little straighter, and she wasn't pulling into that dural tension piece. We changed the way that she was doing her deadlifts so that, she had to go a little bit wider for a while in order to not have that back pain kind of happen. But she could still do the deadlift, and everybody was on board, and she was on board because she could still lift. And I said, as things get better, you can kind of bring your feet in a little bit more.
Yeah. It's amazing what a wide stance does.
Yeah. So we did stuff like that as well. And then, with the if she wanted to run, we talked about, if she had been sitting in that kind of prolonged flex position. Well, first of all, I wanted her to vary her sitting positions a lot. So she had some information on put a towel up underneath you, take it away, sit like this, sit in a different chair, maybe stand for a little bit, but put a lot of variance into her posturing when she had to be on the computer doing a lot of that work. And then we did the same thing with her quilting and sewing. Although she tended to move a lot more when she did that, because you always are reaching and grabbing the stuff and moving around and putting this down and picking this up. So there was already, she already was doing okay with that.
Yeah.
But with the running, we just said, what can you do? I just had her figure out what she could do before she ran that would help her eliminate or mitigate those prolonged postures.
Right.
I just didn't want her to go from that sitting slump to running because it wasn't helping anything.
No.
So besides the variance, she just decided that there were different times of her life where she would go and do it. Right. And so she picked a time that she thought would be fun for her to go and run. Mm-hmm. And, I just kind of said, well, when you ran before, did you always run alone? So it just kind of reminded her to call her friends. Right. Right. Even if you just go for a walk, maybe you just need your mates, this time of your life to go for the walk with you. So some things like that. But so she's kind of moved along here and without having to do quad sets.
Or straight leg raises, active straight leg raises.
Yeah, right?
Oh, that's great. Or like total, like wall sits or, things like that. And, I think it just shows the beauty of the nervous system and the clinical reasoning through someone's activity, because I think a lot of people tend to sort of just focus on one thing. And I think we've brought home in this podcast is to just look at the thing that makes them hurt. Mm-hmm. If you can do it within your clinic, because, mm-hmm. and it seems sort of straightforward, but I think sometimes we get a little, blinded by the fact that the person's got back pain and they can't sit. Well, I'm going to check every lumbar, motion going, or if the person has knee pain, with sitting or whatever, they're going to look at a squat because there's nothing to do. Squatting and sitting are completely different activities. Yeah. One's loaded, one's unloaded, and things like that. And I think with her story, and we talked a little bit about this before getting on. I mean, I think it's about education and educating the patient. And I think that just listening to their story, I think I may have mentioned this once in the past. I don't think every patient, with the exception of acute issues, is looking to get treated the first visit. Literally treated hands-on or whatever. Mm-hmm. They want to understand why they've had their knee pain for so long, or they want to be able to move better. And you can glean that just by talking to them. I mean, you'll know the person. Give me stuff to do. This is, immediately. And I think that, getting them on the table and you need to do those special tests. I mean, haven't done any special tests. I mean, I do them, but I don't even remember half the names, to be honest.
Yeah, names don't matter. I just know what
they don't. But I think that educating the person and giving them ideas, and a lot of times it's what they're doing outside of the clinic that's causing the problem. Mm-hmm. And if you tell them, like I had a patient a couple days ago, she had an issue with, sort of on her hands and knees, that alternate arm, alternate leg sort of stabilization position. She's like, yeah, that makes me feel worse, but I'm continuing to do it. I'm like, why are you continuing to do it if it makes you feel worse? She's like, well, then I decided to do a plank. I said, same thing. You can't. So you have to educate these people on what they're doing outside, especially if they like to exercise. Mm-hmm. Because a lot of times.
That was like the yoga strap,
Yeah.
Exactly. Just show me. I need to see it. Yeah.
I had a patient yesterday. She's like, I'm doing lower trunk rotation. I'm like, show me how you're doing it. She's literally lying on her back, feet off the table, doing like an oblique exercise. I'm like, that's not lower trunk rotation. So it's just spend the extra minute asking the patient to show you what they're doing. Yeah. That was that.
And if you can modify what they're already doing, then you're already going to get them to keep moving because they're already doing it. So
right.
Help them modify it so it's going to be maybe more helpful than irritable for them. Yep, this is great. Thank you.
Love this one.
Okay.
Great story.
Yes, as usual, I'm going to bid you adieu. And to our audience, thank you so much for your listening, your patronage, answering our emails, and sending us information. We'd like to hear. We're going to be sending out some stuff, and you'll see it as we go along. Questions. Please feel free to send us your clinical questions and things that you want us to maybe explore and talk about a little bit. We can devote some of our time to our podcast doing that, and we're happy to do that.
Yeah, it's a great idea. We're thinking of doing like a clinical pearls or something like that podcast. So if anybody has any questions, even if it's just, what do you do with this person or whatever, just feel free to reach out on social media or to either of our emails. I think we're going to do a full podcast on that. So it's great, Susan. Loved it.
That's
Ciao,
right.
everybody.
Bye. Have a great day, everyone.
Bye.